Welcome back for another deep dive. You know the drill. You send us your notes, your sources, and we jump right in.
Yep, pull out the key stuff, try and make sense of it all for you.
Exactly. And today we're tackling pediatric nephrotic syndrome based on those MSRA pediatric revision notes you shared.
Right, so our plan is to walk through these notes together. We'll flag the really high-yield points, connect the dots, hopefully make it stick for your revision.
Okay, sounds good. Let's dive straight in. The basics first. How do the notes define nephrotic syndrome in kids? What is it?
Well, it's a kidney disorder, a renal disorder, with some very specific characteristics laid out on the notes.
Okay, like what?
There's a key triad. First, proteinuria, that's losing a lot of protein in the urine. The notes say more than 1 gram per square meter per day.
1 gram per meter squared. Okay.
Second, hypoalbuminemia, so low albumin levels in the blood, specifically less than 25 grams per liter.
Got it. Low protein in the blood.
And third, oedema. That's the swelling you see, which is pretty widespread.
Proteinuria, hypoalbuminemia, edema, the classic three. And why? What's the underlying issue according to the notes?
The notes explain it's basically due to increased permeability,
Huh.
leakiness, you could say, of the glomerular basement membrane in the kidneys.
The kidneys filter.
Exactly. It gets damaged, lets these big serum proteins, mainly albumin, leak through into the urine when they should be kept in the blood.
So leaky filter, protein loss, low blood protein swelling. Makes sense. But why does the filter get leaky? What about the causes, the etiology section?
Okay, so the notes break this down into primary causes. Well, the kidney itself is the problem, and secondary causes.
Right.
For primary causes, the big one, especially in kids, and this is really key from your notes, is minimal change glomerular disease.
Minimal change. That's the main one in pediatrics.
Definitely the most common. But the notes do list others, like focal segmental glomerulosclerosis, or FSGS,
Okay.
membranous nephropathy, and membranoproliferative glomerulonephritis, though those are maybe seen a bit more in older kids or young adults.
And the secondary causes, you said there was a list.
Yeah, and it's quite a mix in the notes, which is important.
Yeah.
It shows this syndrome can pop up because of something else entirely.
Like what sort of things?
Infections are listed bacterial, viral, even parasitic. Then immunological or inflammatory conditions like lupus or rheumatoid arthritis.
Mm-hmm.
Metabolic issues like diabetes, amyloidosis. Some inherited conditions like Alports. Even malignancies are mentioned, multiple myeloma, carcinomas.
Wow.
And then there are drugs, NSAIDs, captopril, lithium are listed, toxins, pregnancy, even kidney transplant rejection. It's a broad list.
That really hits home that you can't just assume it's minimal change, especially if things don't quite fit the typical picture.
Yeah.
Okay, so with all those potential causes, do the notes mention specific risk factors, things that make a child more likely to get it?
Yes, they do list a few.
Okay.
Genetics can play a role, so genetic predisposition.
Okay.
Infections seem to be a trigger sometimes, particularly viral respiratory ones, or skin infections.
Interesting.
Allergic reactions are mentioned too, certain medications, which ties back to the secondary causes we just talked about, and having other autoimmune diseases.
So things affecting the kidneys or the immune system. Let's circle back to that leaky filter. Can you walk us through the pathophysiology, how the notes describe that step-by-step process from the initial damage to the full syndrome?
Sure. It starts, as we said, with that damage to the glomerular filtration barrier.
Right, the filter.
That damage increases its permeability. The holes get bigger, basically.
Okay.
So proteins, especially albumin, which are normally held back, start leaking through into the urine. That's the proteinuria.
Massive protein loss.
Exactly. And because the body's losing so much protein, the level in the blood drops. That's the hypoalbuminaemia.
Right.
Now, albumin normally helps keep fluid inside blood vessels through osmotic pressure. When albumin levels are low, that pressure drops.
So fluid leaks out.
Precisely. Fluid shifts from the blood vessels into the surrounding tissues, and that's what causes the edema, the swelling. The notes also mention the liver might try to compensate by making more proteins, including lipoproteins, which can lead to hyperlipidemia.
That sequence is clear. Damaged late lyonic, low protein, fluid shift, lice swelling. Very helpful. Now, swelling, kidney issues, these can show up in other conditions too. What about differential diagnoses? What does the source material say we need to rule out?
Good question. The notes list several important ones. Acute glomerulonephritis is one that often presents with blood in the urine, hypertension, as well as proteinuria.
Okay, so slightly different features.
Yeah. Then there's chronic kidney disease, urinary tract infections, UTIs can sometimes cause some protein loss,
Right.
and systemic diseases like lupus, SLE, or Henoch-Schönlein purpura, which can definitely affect the kidneys, and just generally other types of glomerular diseases need to be considered.
So a good checklist to work through. What about how common this is, the epidemiology? Any UK stats in the notes?
Yes, they give UK figures. It affects about 2 in 100,000 children here.
Okay, relatively rare then.
Yeah, and it's a bit more common in boys.
Yeah.
The peak age is usually between 2 and 5 years old.
Young kids mostly.
Exactly. And the notes reinforce here again that minimal change disease is the main cause in this age group.
Right.
And importantly, linked to this epidemiology point, the notes mention that striking stat, about 90% of these kids respond well to high-dose oral steroids.
Wow, 90%. That's huge. And really points toward minimal change being dominant, like you said.
It really does. And they briefly contrast that with adults, where you're more likely to see things like FSGS or membranous nephropathy as the primary cause.
If that 90% steroid response is definitely a high-yield fact to file away.
Okay, so if you suspect a child might have this, what are the clinical signs and symptoms the notes tell you to look out for?
Well, the most obvious thing is the edema, the swelling. The notes say it often starts around the eyes, that periorbital edema, worse in the mornings.
Puffy eyes. Yeah. Then it tends to spread to the lower limbs, genitals, and you can get fluid in the abdominocytes. Weight gain is common because of all that fluid.
Makes sense.
Urine output might go down. And you might notice foamy urine that's literally from the protein in it.
Foamy urine, okay.
Kids might also feel tired, fatigued.
Mm-hmm.
The notes also mention they're more susceptible to infections.
Yeah.
And then there are those internal things like hyperlipidemia and being in a hypercoagulable state, more prone to clots.
Okay, those are the symptoms. What about signs on examination?
Beyond just seeing the swelling, if it's really severe, the notes mention potential breathlessness from fluid around the lungs, a pleural effusion,
Right.
even chest pain,
Right.
possibly indicating something serious like a pulmonary embolism.
Mhm.
But also, paradoxically, even with all that fluid overall, they might show signs of low volume in their blood vessels, hypovolemia, like a fast heart rate, tachycardia, cold hands and feet, maybe low urine output, oliguria. You'd also look for signs of dyslipidemia, maybe fatty deposits called xanthomata. And crucially, look for clues to an underlying secondary cause: fever, rashes, joint swelling.
Anything else specific?
Yes, the notes mention Muirkey's lines. These are paired white lines across the fingernails, linked to the low albumin.
Muirkey's lines. Got it. That's a pretty thorough picture.
Yeah.
So once you suspect it, how do the notes say you investigate? What tests are needed?
It starts with urine tests, logically. A simple dipstick to check for protein, maybe blood.
Okay.
Then a midstream urine sample is really important to rule out a UTI.
Always rule out infection.
Definitely. And then you need to quantify the protein loss. The notes mention using a protein.creatinine ratio or an albumin.creatinine ratio on a spot urine sample.
So measure how much protein they're actually losing.
Exactly. Then on to blood tests. The notes list quite a few: full blood count, a coagulation screen, detailed kidney function tests, UNEs, creatinine.
Standard stuff.
Yep. Liver function tests, a bone profile looking at calcium and phosphate, fasting glucose, and definitely a lipid profile because of the hyperlipidemia risk.
Okay. Comprehensive bloods. What else?
Well, because of those secondary causes, the notes emphasize looking for underlying disease. So tests like ESR and CRP for inflammation, immunoglobulins, serum and urine electrophoresis, a broad autoimmune screen, plus screening for infections like Hep B, Hep C, HIV, and thyroid function tests too.
So casting a wide net for potential triggers.
Exactly. Imaging like a chest x-ray or renal ultrasound might be needed, depending on the clinical picture. And specific scans if you suspect complications like a DVT or PE.
And what about a kidney biopsy? Is that always done?
No, the notes are clear. It's not routine for every child. It's usually reserved for specific cases, maybe if they don't respond to steroids as expected, or they have atypical features suggesting it's not minimal change. Consulting a nephrologist is key here.
Right? Specialist input needed for that decision. Okay, so you've done the tests, confirmed the diagnosis. How does the management section in the notes outline the treatment plan?
The main goals are manage the edema and symptoms, treat the underlying kidney issue, and then prevent or manage any complications.
Makes sense. How do they suggest managing the edema?
Primarily with a low-salt diet.
Yeah.
Then diuretics, loop diuretics are mentioned, potassium-sparing ones, thiazides, sometimes fluid restriction.
Okay.
For very severe edema, IV albumin can be used to help pull fluid back into the blood vessels. But the notes stress this isn't a routine thing. Daily weights are crucial for monitoring.
Got it. What about the kidney problem itself?
Corticosteroids are first line, especially assuming it's minimal change. We talked about that high response rate.
The 90%.
But
Yeah.
the notes also list other immunosuppressants for kids who don't respond, relapse often, or have a different diagnosis confirmed by biopsy.
Like what?
Things like calcineurin inhibitors, cyclosporin or tacrolimus,
Yeah.
alkylating agents like cyclophosphamide, also levamisole, rituximab, mycophenolate mofetil.
Whole arsenal of drugs.
Yes, but the notes rightly point out these come with risks and side effects. It's a balance. They also highlight that relapses are common. Around 80% of kids relapse. So needing these other drugs is quite frequent down the line.
Okay. Any other treatments mentioned?
Managing high blood pressure if it occurs, often with ACE inhibitors or ARBs, treating the hyperlipidemia if it's prolonged. And vaccinations are important, pneumococcal, chickenpox, because of that infection risk.
Good point. Anything the notes say not to do routinely?
Yes, they specifically mention not routinely recommending IV albumin, as we said, and also not routinely giving prophylactic anticoagulation, despite the clot risk.
Interesting. Okay.
And they note some variability in practice regarding things like stomach protection with steroids or calcium vitamin D supplements.
Right. And when should a child be referred or admitted?
The notes say urgent referral to a pediatric nephrologist is needed for diagnosis and management planning. Admission criteria include severe edema, causing breathing problems, really tense genital swelling, developing complications, concerns about compliance, or having nephritic features like lots of blood in the urine, high BP, or worsening kidney function.
Clear indications for escalation. Let's talk about the longer term. What's the prognosis like according to the notes?
Generally, for most children, it's actually quite good, especially for minimal change disease. The notes state around 80% achieve remission with treatment.
That's encouraging.
It is. And they put it in historical context. Before steroids, mortality was over 50%. Now it's dramatically lower, maybe around 3% specifically in children.
That's a massive improvement.
Huge. So the outlook, particularly for minimal change, is excellent overall, but always with the caveat that relapses are common and might need those other drugs we discussed.
Right. The relapse issue keeps coming up. Even with a good outlook, complications can happen. What potential problems do the notes list?
Yes, despite the good prognosis generally, there's a list of potential complications to be aware of. Infections are a big one, like pneumonia or peritonitis. That's partly because they lose immunoglobulins in the urine.
Okay. Increased infection risk.
Increased risk of venous thromboembolism, blood clots. The notes say maybe more so in adults with certain types, but it's a risk across the board due to the protein losses affecting clotting factors.
Right. The hypercoagulable state.
Acute kidney injury can happen too. The notes say this could be spontaneous or triggered by too much diuretic use, NSAIDs, sepsis, or even a clot in the renal vein.
Okay, kidney injury is a risk.
Longer term, there's a risk of chronic kidney disease, especially if the underlying cause isn't minimal change or if the syndrome is steroid resistant. That increases the risk of eventually needing dialysis or a transplant end-stage kidney disease.
Serious long-term consequence there.
Definitely. Other things listed are potential bone problems, osteitis, fibrosis cystica, osteomalacia linked to losing vitamin D binding proteins. It might trigger or worsen hypothyroidism. And anemia can occur, again, due to urinary losses of things needed to make red blood cells.
That's quite a list. Really underlines why careful follow-up is so crucial.
Absolutely. Understanding these potential pitfalls is key to good long-term management.
Well, that was a really thorough walkthrough of pediatric nephrotic syndrome, all based on those revision notes you sent in.
We've really covered the core areas: definition, causes, the pathophysiology, who gets it, how they present, investigations, management, prognosis, and those potential complications. Hopefully structuring it like the notes helps it lodge in your memory.
Yeah, breaking it down section by section hopefully makes this complex topic feel a bit more digestible for revision.
We hope this deep dive has helped clarify things for you.
And that leads us to our final thought for you to ponder, based on what we've discussed.
Right. We've mentioned several times that while the prognosis with steroids is great for most kids with minimal change, relapses are really common, affecting maybe 80%. So the final thought is this: beyond the medical treatments and monitoring, what are the wider, perhaps less obvious impacts on a child and their family of dealing with a chronic condition that frequently relapses like this? Think about quality of life, school, family stress, something to mull over.
A very important point to consider. Well, thank you again for sharing your sources and allowing us to take this deep dive.
Yes, thank you. Keep up the hard work with the revision.
And remember, for more help with your MSRA prep, do check out PassTheMSRA.com and also FreeMSRA.com.
Great resources there.
We'll catch you on the next deep dive.